Hello everyone. I'm myself Dr. Rajesh Gubba. I'm the general medicine educator. In this session, I'll be doing a quick recap of the topic of the hyperaldosteronism. So, first of all, you need to know where is this aldosterone secreted from? Aldosterone, it is secreted from zona glomerulosa of adrenal cortex. Adrenal cortex, it has three layers: zona glomerulosa, fasciculata, and then reticularis. So glomerulosa is the one which will produce the aldosterone, and reticularis, they produce steroids. And zona glomerulosa aldosterone, zona fasciculata corticosteroids, and zona reticularis the weak sex hormones. And what is the site of action of the aldosterone? Aldosterone, it acts on the principal cells of the distal convoluted tubule. That is the site of action of aldosterone. And what is the normal function, or what is the action of the aldosterone? Aldosterone, it causes the reabsorption of sodium and water, and it will cause the excretion of potassium and as well as the H plus ion. That is what is the normal action of the aldosterone. Next, followed by that, what is hyperaldosteronism? As the word itself tells you, it is the disorder which is associated with hypersecretion of the major adrenal mineralocorticoid, that is aldosterone. That is what is your hyperaldosteronism. Then, how do you classify this hyperaldosteronism? We have two forms of the hyperaldosteronism. One is the primary hyperaldosteronism. Primary hyperaldosteronism is that where the pathology is directly within the gland, right? Either it is adrenal adenoma or adrenal hyperplasia that will produce excess amount of aldosterone. And secondary hyperaldosteronism, it is due to extra adrenal stimulus. So this secondary hyperaldosteronism, it is due to excessive activation of renin-angiotensin aldosterone system that will make the individual to develop secondary hyperaldosteronism. Now, you need to know what is the most common cause of the primary hyperaldosteronism. The most common cause of primary hyperaldosteronism is the adrenal adenoma, and that too unilateral adrenal adenoma that constitutes nearly around 70% of causes of primary hyperaldosteronism. And what is the Conn syndrome? Conn syndrome is the clinical condition which is characterized by hyperaldosteronism due to adrenal adenoma. See, hyperaldosteronism, it can be either primary and secondary. Primary hyperaldosteronism, again, it is due to adrenal adenoma or adrenal hyperplasia. And if this hyperaldosteronism is due to adrenal adenoma, that is called the Conn syndrome. And what are the other causes of the hyperaldosteronism? The other causes of hyperaldosteronism include bilateral adrenal hyperplasia that accounts for 25 to 30% of cases. Then, very important question, what is the herb which has action similar to aldosterone? Please remember, it is licorice. Licorice has the aldosterone-like qualities, and excessive black licorice ingestion can mimic this effect of hyperaldosteronism, right? Next, followed by that, what are the causes of secondary hyperaldosteronism? That includes congestive heart failure, cirrhosis of liver, and then hypotension and hypovolemia. See, in all these clinical scenarios, there will be decreased renal perfusion. Right, there is decreased renal perfusion. So because of decreased renal perfusion, there is excessive activation, there will be excessive renin, and that will cause the excessive activation of RAS. And this RAS, it stands for renin-angiotensin aldosterone system. So more and more activation of renin-angiotensin aldosterone system, more and more aldosterone is being produced. So the causes of secondary hyperaldosteronism are congestive heart failure, cirrhosis of liver, hypotension, and hypovolemia. Then, what is the difference between primary and secondary hyperaldosteronism? So you need to know, in primary hyperaldosteronism, the initiating event is increased aldosterone production. So once there is increased aldosterone production, that will cause sodium and as well as water retention. So when there is more and more sodium and water retention, there is increase in the intravascular volume, and that will increase the renal perfusion. So once there is increase in the renal perfusion, that will cause decrease in the renin levels, right? That will cause decrease in the renin levels. Now, if you see secondary hyperaldosteronism, in secondary hyperaldosteronism, what is the initiating event? The initiating event in secondary, it is decrease in the intravascular volume. And this decrease in intravascular volume, it could be due to hypotension, or it could be due to dehydration, or it could be due to cirrhosis of liver, or it could be due to congestive heart failure. So once there is decreased intravascular volume, there will be decreased GFR, and that will cause the excessive production of renin. And this excessive production of renin will cause increased aldosterone production, and this will subsequently cause increased sodium and water retention. So please remember, in case of primary hyperaldosteronism, there is decreased renin. In secondary hyperaldosteronism, there is increased renin. That is a very important difference between primary and as well as the secondary hyperaldosteronism. Then, what are the clinical manifestations of primary hyperaldosteronism? The clinical manifestations include, number one, the development of the hypertension. And what type of hypertension is commonly seen? It is the diastolic hypertension, which is commonly seen in patients with the primary hyperaldosteronism. And this aldosterone will cause the excretion of potassium. Thereby, the individual will have low potassium levels. So primary hyperaldosteronism is characterized by hypertension and low potassium levels. These are the clinical manifestations of primary hyperaldosteronism. Now, what are the features of hyperaldosteronism due to hypokalemia? So, due to hypokalemia, please remember, the individual will have the muscle weakness, polyuria, polydipsia. These are the features which will appear due to hypokalemia. And when do we use the word hypokalemia? When the potassium levels are less than 3.5 milliequivalents per liter. That is the point when we use the word hypokalemia, right? Next. Now, why there is metabolic alkalosis in hyperaldosteronism? Please remember, in patients with hyperaldosteronism, there is excretion of the H+, which is acidic in nature. So due to excretion of the H+, these individuals will develop the metabolic alkalosis, right? The pH will be increased in patients with the hyperaldosteronism. Then, is there edema in primary hyperaldosteronism? The answer is no. Edema is uncommon with primary hyperaldosteronism because of sodium release into the urine. See, normally when there is increase in aldosterone, that will cause the sodium retention. But when this sodium is excessively retained, that will again come back to the renal tubules. So there will be increased sodium load in the tubules. That will cause the pressure natriuresis. Renal tubule cannot handle this excessive sodium load. Renal tubule cannot handle excessive fluid volume. Thereby, there will be pressure diuresis and pressure natriuresis. Because of this pressure diuresis and pressure natriuresis, please remember, there is no edema. Edema is not the feature of primary hyperaldosteronism. This is a very, very important point. And this is called as the aldosterone escape phenomenon. So what do you mean by the word aldosterone escape? Because aldosterone, even though it is there, it is unable to show its action of sodium and water retention. And that is the reason why it is called the aldosterone escape phenomenon, right? Next. Then you need to know the differences between the primary and as well as the secondary hyperaldosteronism. In primary hyperaldosteronism, you have the presence of the diastolic hypertension, but you will not have the same in secondary hyperaldosteronism. Then followed by that, the muscle weakness. Muscle weakness is characteristically seen in case of primary rather than secondary, and this muscle weakness, it is mainly due to hypokalemia. Right, it is due to hypokalemia. And what about polyuria and as well as polydipsia? Even that is seen in patients with primary rather than secondary. And why is that? That is again due to hypokalemia. And what about edema? Edema is never present in primary, and in secondary it may be present. Why? Because some of the causes for secondary hyperaldosteronism are congestive heart failure and cirrhosis of liver, and in congestive heart failure and cirrhosis of liver there will be presence of the edema. So in some cases of secondary hyperaldosteronism there can be presence of edema. And what about hypokalemia? Hypokalemia will be present in both. Why? This aldosterone will cause the excretion of the potassium that will make the individual to land up in the hypokalemia. Next, what about hypernatremia? Hypernatremia will be present in primary, but that hypernatremia is absent in patients with the secondary hyperaldosteronism. Why is that? Because you see, what are the etiologies which will cause secondary hyperaldosteronism? Like congestive heart failure. In patients with congestive heart failure, there is fluid overload. Once there is fluid overload, that will make the individual to develop what is called dilutional hyponatremia. Right? That will make the individual to develop dilutional hyponatremia. And what about metabolic alkalosis? Metabolic alkalosis will be present in both. Why? Because of the excretion of H+ ion. That will make the individual to develop metabolic alkalosis. So these are the differences between primary and secondary hyperaldosteronism, right? The very important difference: muscle weakness, polyuria and polydipsia, and edema, they may or may not be present in secondary, and even hypernatremia will not be there in secondary, right? Now, followed by that, how do you diagnose this hyperaldosteronism? What will be the primary screening test? The primary screening test is the plasma aldosterone concentration and plasma renin activity. So plasma aldosterone concentration is increased in both primary and secondary, but renin activity, it will be less in primary, it will be more in secondary. So that is a very important point you need to know. So a positive screen is plasma aldosterone concentration to plasma renin activity. If it is more than 20:1, that is suggestive of the primary hyperaldosteronism, and the plasma aldosterone concentration should be more than 15. So that is what is the terminology. That is when we use the terminology hyperaldosteronism. That is when the plasma aldosterone concentration is more than 15. Then what will be the confirmatory test? The confirmatory test in patients with hyperaldosteronism is sodium chloride challenge test. So which is nothing but oral salt, right? Oral salt loading test. Right? Oral salt loading test. That will be the confirmatory test for hyperaldosteronism. And this can be via the normal saline, sodium chloride tablets, or the fludrocortisone. So these are the confirmatory tests for hyperaldosteronism. And you need to know what is the normal response of sodium chloride challenge test. See, when you do a sodium chloride challenge test, the plasma aldosterone concentration should be suppressed in a normal individual because you are increasing the fluid. So once you are increasing the fluid, that will increase the renal perfusion, thereby the plasma renin levels will be reduced and subsequently there will be decrease in the aldosterone levels. But in patients with hyperaldosteronism, the plasma aldosterone concentration, it is still elevated in spite of giving or in spite of doing the oral salt challenge test. And this will confirm the diagnosis of the hyperaldosteronism, right? Next. Now, what is the treatment of choice for adrenal adenoma? Please remember, adrenal adenomas, most of the times they are unilateral, and unilateral adrenal adenomas, they are removed surgically. So surgical resection of the tumor, that will be the treatment of choice for adrenal adenoma. Whereas, what is the treatment for bilateral adrenal hyperplasia? If there is bilateral adrenal hyperplasia, you need to give the aldosterone antagonist. And what is the example of the aldosterone antagonist? That include the spironolactone. So what this spironolactone will do? Spironolactone will block the aldosterone release. But the problem with the aldosterone is that this can cause the painful, right? This can cause the painful gynecomastia. So in order to avoid this painful gynecomastia, the alternative drug, right? The alternative drug, it is eplerenone. Right? Alternative drug is eplerenone. So that is the treatment for bilateral adrenal hyperplasia. Then lastly, what is the treatment for secondary hyperaldosteronism? The treatment for secondary hyperaldosteronism is you need to treat the underlying cause. Like if it is the cause is hypotension, or if the cause is congestive heart failure, or if the cause is cirrhosis of liver, treat that underlying cause. That will automatically treat the secondary hyperaldosteronism. So this is about the hyperaldosteronism. So please remember, primary most common cause will be adrenal adenoma. Secondary most common cause will be congestive heart failure. The very important differentiating feature is the plasma renin levels. Plasma renin levels is less in primary. Plasma renin levels are high in secondary. Treatment wise, in case of primary, surgical resection of the tumor if it is adrenal adenoma, and spironolactone if it is bilateral adrenal hyperplasia. And secondary, how will you treat? You need to treat the underlying cause. That completes the discussion of the hyperaldosteronism. Thank you very much.